All right, welcome everybody to the NF1-PN lecture library. Today we're going to talk about recent progress on NF1 plexiform neurofibromas, pathophysiology, role of MEK inhibitors, and recognizing NF1 or neurofibromatosis type 1 plexiform neurofibromas in a patient. Really excited to have you guys today. My name is Amy Armstrong. I'm an associate professor of pediatrics and also a pediatric oncologist here at WashU. In St. Louis. We also have a neurofibromatosis center affiliated WashU, and I have the privilege of heading our solid tumor program, co-directing our AYA sarcoma program, and then being our principal investigator for the NF Clinical Trials Consortium Network as well. And my disclosures are as listed. The learning objectives for today are as outlined. I promise you I'll take you kind of bullet point by bullet point as we go through the talk, and we'll just get started here with the pathophysiology of neurofibromatosis type 1 plexiform neurofibromas. So before we hit neurofibromas within NF1, it's really important to understand how common the mutation NF1 can occur and how many people are diagnosed kind of throughout the world with NF1 as well. So it's the most frequently inherited single gene disorder of the nervous system, and we classify it as the most common tumor predisposition syndrome as well. It occurs in approximately 1 in 3,000 live births. In the literature, you might see anywhere from 1 in 2,500 to 3,500 individuals, and it's characterized by a genetic mutation, the NF1 gene, that has been recently described. That's on chromosome 17. We know that the NF1 gene encodes for neurofibromin, which is known to be a tumor suppressor. So obviously, without that tumor suppressor active, we have very active pathways in multiple parts of our body that can lead to tumor development. And really, this is active in nearly every tissue lineage. Holocorporal loss of 50% of functional neurofibromin can impact every organ system in the body. And we know that patients who have a mutation in NF1 will have 100% penetrance, meaning that they will exhibit clinical manifestations of neurofibromatosis type 1. As I mentioned, lack of functional neurofibromin will lead to this hyperactive RAS, and it's a signaling cascade network, which we'll show you on subsequent slides. But really, with that hyperactive RAS pathway, we can see a lot of different types of tumor inflammation. Now, within the context of NF1, there's a variety of clinical presentations that will arise, but I think what's really important to note is that they don't all start from day one or at birth. So as a patient with NF1 ages and advances throughout their life, different things may be expected or can develop. And so different clinics, my adult versus pediatric, will be aware of looking out for some of these. Most importantly, I'd say at birth, we can see some of the skin signs of NF1 with cafe au lait macules, which I always say is kind of a light colored coffee color, which is the cafe au lait, and a macule, just a flat skin color. And we'll show you what those pictures look like on later slides as well. You can see bony abnormalities in young kids. And then we really believe that the plexiform neurofibromas, which is the bulk of the talk today, arise in the congenital period. So we have kind of a tumorigenic Schwann cell, which we'll talk about later, but really that start of tumor formation, that nidus, likely exists at a very, very young age, even at birth, and then will grow and advance as that patient ages. As kids with NF1 get to preschool years, early childhood education, you'll start to see some learning deficits, not with everybody, but with some, potentially some motor or speech delays, autism spectrum, or ADHD. Then also this optic pathway glioma, which is pretty pathognomonic for NF1, will start to arise as well. Now, as we hit adolescence, you'll see a little bit more of the skin fold freckling, leash nodules, which are abnormalities within the eye, scoliosis, different areas where neurofibromas can arise, and then brainstem gliomas. Then once we're in adulthood, we can see some of the more aggressive malignancies, like a malignant peripheral nerve sheath tumor, breast cancer, some of the high-grade gliomas. So I know my adult counterpart at WashU at least starts screening for breast cancer at the age of 30. And we're very cognizant of adolescent to young adult, if a plexiform neurofibroma might be misbehaving or something's changing, having that high level of suspicion for something like a malignant peripheral nerve sheath tumor. Now, NF1 and peripheral nerve sheath tumors, how do they start in the first place? As I said, that with the plexiform neurofibroma, which is qualified as a peripheral nerve sheath tumor, it starts in really that congenital period or at birth. And what we believe is that the Schwann cell, which is one of the cells that comprises kind of the nerve bundle or the peripheral nerve bundle, has a second hit in NF1 and really becomes tumorigenic. And so what it starts to do is it recruits cells to its tumor microenvironment. You can see some of these environmental cues here, but it's calling in the fibroblasts, the macrophages, the mast cells, all things to really kind of start to make this bulkier tumor formation from this cell that's signaling out, asking for its friends to come into the tumor microenvironment, as I say. We know that about 50% of individuals who have NF1 will develop a plexiform neurofibroma. And I would say anytime you see a plexiform neurofibroma, or if you have a pathology diagnosis of one, have a very, very, very high level of suspicion for NF1. I've only seen one or two cases throughout my career in which a plexiform neurofibroma arises outside of the context of NF1. We believe that these tumors are histologically benign, so not necessarily, aggressively malignant, won't metastasize, that kind of thing, but they can cause substantial morbidity. And if we really think about where peripheral nerves are located throughout the body, and then we think about a tumor arising from that location, you can imagine you might have airway compromise if something's in the neck. If it's by the spinal cord, you can have spinal cord compromise. You can have a lot of disfigurement. You might have vision issues. So things that are on the face, which are really hard, obviously, to cover with clothing, can be really creating a lot of psychosocial issues for a patient. Vision issues, as I already mentioned, issues with mastication, arms and legs, just really range of motion, just general mobility. And then we know in about 8 to 13% of patients who have an NF1 plexiform neurofibroma, they can go on to develop into a malignant peripheral nerve sheath tumor. So additional genetic changes are required in some of the cells within the plexiform neurofibroma, which unfortunately leads to the most common cause of death in a patient who has NF1. So the natural history of NF1 plexiform neurofibromas is that we think that they, develop at a very, very young age, and we know that they grow the quickest, the most rapidly in the youngest of children. So you'll see under the age of 5, some reports will say under the age of 8, but really in those young kids, as they're growing, we see their tumors really grow as well. I'll say once we hit mid-adolescence to young adulthood, usually the growth rate for the tumors pretty much stabilizes off, which really goes into some of our treatment recommendations for where we feel like the risk is for that patient. These tumors can be highly infiltrative, most frequently located in the trunk or the extremities of a person. On imaging, you can see this multinodular, sometimes it looks like a bag of worms, but discrete nodules, and we'll have some pictures for that too, enlargement. As I mentioned, they can obstruct major organs like an airway or a spinal cord, which obviously can be life-threatening. They can be disfiguring and painful. I didn't mention pain on the prior slide, but sometimes the indication for treatment is that these tumors are extremely painful and very bothersome and getting in the way of day-to-day activities for an individual. And we also see that the morbidities tend to worsen over time without any treatment provided. Symptomatic PNs tend to be larger than asymptomatic PNs. I think that can probably speak for itself. And then, as I mentioned on the prior slide, the risk of malignant transformation to a malignant peripheral nerve sheath tumor. Now, the morbidity burden is huge for both pediatric and adult patients with NF1. And common complications, again, can include pain, difficulty with motor function, motor deficits, or weakness. Rare PN-related comorbidities include vision issues, bowel or bladder dysfunction, or even obstructive sleep apnea, if we think about where some of these things are located. Then the potentially life-threatening complications can include their transformation into a malignant peripheral nerve sheath tumor, or potentially in a younger kid, just airway compromise or that spinal cord compression. And we know that MPNSTs have a high rate of metastases with a survival that unfortunately is less than 5 years if you have a metastatic presentation up front. Many patients will need surgeries that are associated with varied outcomes kind of to date. For a variety of other NF1 complications. I'll also add that in the past, surgery is the only treatment option that we had for patients who had plexiform neurofibromas. So now we're kind of revisiting what an appropriate treatment modality will be. And we know that patients are known to report a lot of psychosocial issues, which I'm sure we can all understand can really impact just quality of life. And then children with NF1 and asymptomatic PN have a higher mortality rate, which has been reported. So what are the current management options and unmet needs for a patient who has an NF1 related plexiform neurofibroma? So the treatment options, if you've identified one of these tumors, one I would say is that you do nothing, that you observe. So first we want to understand, is that tumor problematic? We've identified that it exists, but do we need to do anything about it? And I feel like that's always the very first thing that needs to go into consideration. So looking at the age of the patient, the symptoms, a new symptom that might arise and risk for malignant transformation, making sure that's ruled out. But if a young kid comes to me with an identified plexiform neurofibroma that's not causing any issues, I might want to keep a closer eye on it just due to the growth rate, but that might not warrant treatment. Now, for the patient who is symptomatic, who has a tumor that's aggressively growing and potentially, if it continued to grow, would cause more compromise, again, difference between young adults and older children's, what do we do next? So we know that complete resection, so complete removal of the entirety of the tumor, can be extremely difficult. These tumors are really infiltrative. They involve a lot of vascular supply, nerve supply. Unlike some of the other tumors I treat that are more circumscribed, well-defined borders, these things just kind of interdigitate, I would say, within the anatomy around them. So for a surgeon to go in and just scoop it out isn't often possible. We also know after resection that regrowth can definitely happen. It's reported in about 50% of patients. Now, some patients may benefit from a debulking, so removing a part of the tumor, but not all of the tumor. Again, we understand that growth can occur afterwards, but sometimes in that acute period, that may be the option that is needed. And then there's been an unmet need for medical therapy, as you guys can understand in just listening to me, for those patients that are symptomatic and where surgery is just not really a good option. To date, we've understood that conventional chemotherapy or radiotherapy has really limited clinical benefits. So for better or for worse, chemo is not going to do anything to these tumors. They're very slow growing, very unique pathways. And really throughout the past, I would say decade, an improved understanding of that molecular pathway, and in particularly the hyperactive RAS pathway, has led to a huge shift in how we can treat these patients with definitely some benefit. So that leads us over to MEK inhibitors. And why would a MEK inhibitor be helpful in a patient who has a hyperactive RAS pathway within an NF1-PN? So as I mentioned, mutation NF1 leads to loss of neurofibromin, and all of a sudden that stop sign no longer exists. So you have this RAS pathway that's hyperactive, and it goes RAS, RAF, MEK, ERK. And then you have cellular signaling and other processes down here. What we've learned by putting in that stop sign higher up with a MEK inhibitor and stopping that pathway or quieting that pathway, that we can really achieve some tumoral control within these lesions, which is absolutely great. The MEK inhibitors that are bolded there, the selumetinib and mirdametinib, are the two that have an FDA-approved label right now for the treatment of NF1 plexiform neurofibromas. That being said, there are other MEK inhibitors on market. So we have binimetinib, trametinib, luvometinib, which is more abroad from me right now. And then we also have multi-tyrosine kinase inhibitor, cabozantinib, which has shown some clinical activity in particularly some older patients, older than the age of 16. So going to selumetinib, this has been FDA approved since April 2020. The label actually just changed. It used to be for 2 years of age and older pediatric patients. But now that they have a sprinkle formulation that actually just dropped down to 1 year of age, and then mirdametinib just received its FDA approval in February 2025 for the treatment of both children and adults with plexiform neurofibromas. And I would say the differences between these two, which we'll talk about in later slides, is really the dosing administration. Selumetinib's twice daily, indefinitely, with each cycle being 28 days. Mirdametinib is twice daily for 3 weeks, and then 1 week off. Each cycle is also 28 days. And now that selumetinib has a sprinkle formation, it can be given to children who can't swallow pills. Mirdametinib has an option for a pill formation and then also compounding into a liquid formation. So the clinical trials that really got us to these FDA approvals, I feel like are just landmark studies. And you'll see with the SPRINT study, it was published in the New England Journal of Medicine, which should really tell you about the clinical significance and the impact that these MEK inhibitors are having and truly transforming the treatment pathway for patients with NF1 related PNs. But the SPRINT study, again, the landmark study, was a phase 2 open label pediatric study, so for children aged 2 to 18. And the dosing of selumetinib was 25 milligrams per meter squared and was based on body surface area, or BSA. They were able to enroll 50 patients, and ultimately their primary endpoint for being on drug was how did the tumor shrink while being on therapy. And so looking at partial response, I would say in plexiform neurofibroma studies, unlike some of our other solid tumor studies, we define a partial response as a 20% volumetric reduction in that tumor burden. And I would also add that doing these volumetric analyses are extremely sophisticated and have really required, I would say, advanced radiologic approaches. And we're also trying to understand how we can kind of compare some of these volumetric analyses across studies. But partial response is the primary endpoint, and then making sure it was confirmed and durable. Secondary endpoints being the duration, the safety, and then obviously patient observed reporter outcomes. So the baseline demographics for this study was a median age of 10, predominantly male, but 40% female. The initial target NF volume was about 487 milliliters. And you have patients who are coming in with either progressive tumors or not necessarily progressive, but symptomatic, which would have been one of the eligibility criterias, and then located in a variety of places throughout the body and also the variety of comorbidities, but disfigurement, motor dysfunction, pain being the top ones, as well as some airway compromise, vision, bowel or bladder dysfunction, or other. The initial review for the 3-year outcome with selumetinib in comparison to kind of the natural history or historical controls here showed a partial response rate of 74%. And so what they're really reporting is that at least 74% of patients had at least that 20% reduction in tumor size. Now, the confirmed partial response rate went down a little bit to 68%, and the durable responses were seen at 56%. The time to reach these responses takes a while. So it took like 16 cycles. So 8 for that initial response, 16 cycles for the best response. Again, each cycle is 28 days. So what I always tell my patients is we're in for a marathon, not a sprint. We're in it to really see if this drug is going to work. And as long as we're tolerating it okay, it might be that we're in, 6 months, a year and a half before we're still, or before we're able to see the activity that we're looking for. The median duration of response and progression-free survival were not reached. Then additional outcomes would be that the median change in tumor volume was a reduction by 28%. And then a lot of people did have decrease in pain and other improvements in PN-related complications, as well as function and quality of life. Looking at safety data, which is equally as important, I feel like, as response, how easy is it to take these medications? And obviously we don't want to do harm to our patients. Most commonly what we're going to see, and this is pretty much for all MEK inhibitors, is nausea, vomiting, diarrhea, so GI side effects. An asymptomatic increase in creatinine phosphokinase, or CPK, acneiform rashes, and paronychia, all very common AEs. Adverse events that led to dose reductions happened in about 28% of patients. And then for patients who ultimately had treatment discontinuation, that was for 5 who had a progressive tumor, 2 had stable disease, and then 5 due to adverse events. And then they reported 9 for other reasons. Then they ended up combining data from phase 1-2 trials, looking at 5-year outcomes with selumetinib. Again, this is all in children with inoperable PN. This cohort included 74 patients, continuous selumetinib dosing. Really, the duration was 57 cycles. So think about, you're looking at a long amount of time that patients are on this therapy. And a lot of patients, I would say, on the initial SPRINT trial wouldn't end after 2 years. They would go on and continue. Again, that partial response rate was confirmed for this larger cohort at 70%. It was durable for 59%. Time to response initially still taking 8 cycles and then up to 18 cycles for that best response. Progression-free survival, the median was 88 cycles, which was really excellent. And then 1-year probability of being progression-free after 60 cycles was 61%. So really great data, and you can understand how that led to some of the FDA approval. Now, selumetinib was also studied in adults with inoperable PN, also phase 2 study. This was conducted at the NIH. Similar dosing in that 25 milligrams per meter square. The equivalent on the adult end is 50 milligrams BID. There are 33 patients that were enrolled on the adult study. Primary endpoints were the same, and key secondary endpoints were understanding the longitudinal analysis of tumor volume, patient-reported functional outcomes, and then biomarker responses. And then here you can see it was 33 patients. The median age here was 36 years, still a little bit more male, 64%, so about 36 being female. The volumes of the tumors were a little larger, so over a liter, so 1170 milliliters was the median volume. There were 4 patients who had progressive disease before enrollment. That's in comparison to the children, where you're going to see more progression coming into treatment. And then the location of the target PN also varied. And then the comorbidities that led to enrollment: pain, again, very common that we'll see that in our clinic, motor dysfunction, disfigurement, then again, a little bit less with bowel or bladder, airway, or other. Outcomes with selumetinib in adults with inoperable PN is that of the 33 patients, you saw a partial response in 64%, stable in 36%, and 0 had progressive disease. The median time to progression was not established. The best change in tumor volume was a reduction by 24%, with the range being a reduction by 48% to a growth of 6%. And the median time to first response was 12 cycles, best response 20 cycles. So again, long durations of therapy for these patients. AEs very similar as well. So the acneiform rashes, increase in CPK, dry skin, itchy skin, pruritus, increase in ALT and lymphedema was reported. All right, moving on to the COMET study, which was a really interesting phase 3 international study using placebo. And so what they did was a double-blind study, adult patients, so age 18 and above, NF1 with symptomatic plexiform neurofibromas, and you would enroll to the dosing of 25 milligrams per unit squared or 50 milligrams BID or placebo. The interesting thing, though, was patients would be on this medication for 12 cycles, and then those who are on placebo would cross over to selumetinib for the next 4 cycles, and then they did their analysis at cycle 16. The reason they designed it that way is they didn't expect to see much of a change in 4 cycles, but in my opinion, I think it clouds the analysis just a little bit in really understanding the difference between selumetinib and placebo. For the patients enrolled, there were 71 on the selumetinib arm, 74 on the placebo arm. The age was a little bit older, 28 to 31. There were only, I feel like, a few US patients who were enrolled. The majority of these were international and Asian-based. Target NF volume, some smaller, so 92 milliliters to 222 milliliters, and that's in comparison to like the 1 liter I just gave you on the adult expansion of the prior studies. Then the location of the PN varied, and then obviously a lot of patients also had pain. And if we go to the response here, the partial response on those patients who received selumetinib was a 20% partial response rate. And so that was, again, a 20% reduction in tumor volume in comparison to the placebo arm, where they felt like it, or they reported a 5% partial response rate. The difference they felt was significant and that they met their primary endpoint here. And the best change in tumor volume for the partial responders was down to a 34% reduction with a range of 58 to 23% for reduction. Again, selumetinib versus placebo by cycle 16 was where they were doing their comparison purposes. Clinically and significant objective response rates, and then reduction in target PN volume was what they were looking for. All right, moving over to the COMET study as far as the pain score, I'd say overall, there maybe wasn't as significant of a reduction of pain that they saw in the adult patients, but if you looked at individual components for different pain scores, they did see a statistically significant difference in reduction of pain. And I feel like it's very similar to what we see in the clinic and on our trials. Usually being on this med when you have pain leads to a reduction of pain. How we define that and how we show that from a clinical trial standpoint obviously always differs just a little bit. Now we're going to switch gears a little bit from selumetinib and move over to mirdametinib, which leads us to the RENEW trial, which is the landmark study for mirdametinib. It was done in both children and adults who had inoperable symptomatic plexiform neurofibromas in the context of NF1, and it was a phase 2b study. Mirdametinib dosing was 2 milligrams per meter square, given twice daily. Again, 3 weeks on, 1 week off. So that's the biggest difference between dosing between these two medications, with a maximum dose of 4 milligrams per meter square. You could be on treatment for up to 2 years. The pediatric cohort was 2 to 17, adults are 18 and up. And then you can really see that they, a nice mix of who they were able to enroll, but 56 children, 58 adults. The median age was 10 in the pediatric cohort, 34 in the adult cohort. Male, 46% on peds, 36% on adults. Variety of locations of PNs. You can see them kind of broken down here. And then the complications: pain in a large majority of patients, disfigurement or a major deformity, and then motor dysfunction, airway dysfunction, or other. And for progressive tumors, they actually had 62% deemed as progressive in the pediatric cohort and 53% in the adult cohort. The primary endpoint here, similar as most clinical trials with NPN, but looking at that partial response rate. So again, that 20% reduction. And then secondarily, the duration of response, safety, and then quality of life and physical functioning. Looking at the actual outcomes, they divided it between the pediatric outcomes and the adult outcomes, but pretty similar. In the kids, there was a 52% partial response rate, 39% were stable, and 5 had progressive disease. And then on the adult side, 41% had partial response, 45% stable disease, and 0 had progressive disease. The median duration of response was not met. The best change in tumor volume was interesting in that the median was maybe a little bit more, but 42% reduction in kids, 41% reduction in adults, with the range going down to the 90% reduction. So if you're starting here, you're really, really shrinking that up to growth at the positive 48 or positive 13. And then time to first response took about 8 cycles. So the median range there, the median value there, with the range being 4 to 18 cycles in kids, and then 4 to 19 cycles in adults. Understanding the most treatment-related adverse events that occurred in over 20% of the population treated. In kids, the acneiform rash, so dermatitis acneiform, diarrhea, paronychia, nausea, the ejection fraction decrease, increase in CPK, and then on the adults, the acneiform rash as well, diarrhea, nausea, vomiting, fatigue. So as you see, a lot of these toxicities kind of overlapped amongst the MEK inhibitors. Now moving over to a different MEK inhibitor, a MEK1, MEK2 MEK inhibitor, luvometinib, which has been studied, I believe, in some of our Asian regions. This was done in a phase 2 trial, open label, pediatric. The dosing was 5 milligrams per meter squared daily, and they enrolled 46 patients under the age of 18. Treatment cycles were 28 days, no rest in between cycles, so continuous as well. Primary endpoint for this study was an investigator-assessed partial response per the RAINS criteria. And key secondary was a blinded independent review committee assessed partial response, other efficacy endpoints, and safety and clinical outcomes. For this study, the median age was 8 years, predominantly male at 67%. They also looked at NF mutational status, which is a little bit interesting as far as the germline mutations that they picked up or did not pick up. So 87% were positive, 9% were negative. I'd be curious how deep some of those analyses are. And then 4% unknown. Their volume of target NF, they did centimeter cube, was 38. And then the mass majority were enrolled for disfigurement or pain. Median duration of treatment was about 25 months for their partial response, initially by their own investigator review was 60%, but then per blinded independent review committee, that was down to 44% for patients who achieved a partial response or at least a 20% reduction in tumor size. Dose interruption due to treatment emergent adverse events, they had none as far as that led to a dose reduction, discontinuation, or death. And they had 10 patients who had grade 3 or more toxicity. And for their toxicity profile, again, somewhat similar, but acneiform rash, CPK elevation, they mentioned a folliculitis, and we've definitely seen some skin issues on these MEK inhibitors, paronychia, upper respiratory tract infection, ejection fraction decrease, and then they also mentioned some pneumonia, herpangina, anemia, and GI disorders. All right, moving over to binimetinib, which is a MEK1, MEK2 inhibitor. This was studied through the PNAC study and also the NF Clinical Trials Consortium study. It was a phase 2 trial for pediatric and adult patients. needing either a progressive, symptomatic, and inoperable PN. Binimetinib was dosed continuously, 32 milligrams per meter squared children as the starting dose and 45 milligrams per dose on the adult end. And then the treatment cycles were 28 days. For the primary endpoint for here, the partial response at 12 months was what they were looking at. Again, that 20% volumetric reduction, and secondary endpoint was safety. So baseline demographics for the data that we have available right now, and I do know that this is getting close to publishing for a bit more details for reference moving forward. But the median age of patients was 12 years for the pediatric cohort, 55% male, and then that target tumor volume was 326 milliliters. On Bini, the partial response rate here in the kids, the children cohort was 74% for a partial response rate. 14 out of 19 patients had a 20% volumetric reduction. The median maximal PN volume change was by a 26% reduction, ranging from 54% down to 9% down, and requiring a dose reduction in 13 patients. 2 patients discontinued due to drug toxicity, and then the grade 3 toxicities that were listed were dry skin, weight gain, muscle weakness, rash, paronychia, cellulitis, diarrhea, gastric hemorrhage, and a CPK increase. And then lastly, we'll go to a multi-tyrosine kinase inhibitor, which acts differently than the MEK inhibitor. So again, the MEK inhibitor tries to prevent the hyperactive signaling that happens from the RAS network, so the RAS, RAF, MEK, ERK. Cabozantinib's goal is to get in the way of cellular signaling kind of coming or emanating out from that tumorigenic Schwann cell. So trying to get in the way of KIT signaling, how the Schwann cell interacts with the mast cell, VEGF-R inhibition for some of the neoangiogenesis that we can see in the tumors. Cabozantinib has a lot of different targets as far as one of our multi-tyrosine kinase inhibitors. But it was studied in both pediatric and adult patients who had progressive or inoperable symptomatic NF1-PNs. And then on the adult side, that was classified as 16 or above. The dosing for cabozantinib is daily. We enrolled 21 patients on the adult cohort. Started at initial dosing for 2 cycles, not just 2 weeks, and then would advance thereafter. And then the primary endpoint for this study was a partial response in 25% of patients after 12 cycles. So again, looking for that 20% volumetric reduction after 12 cycles. If you did not have that, you had to come off study. And key secondary endpoints are tolerability and safety, patient-reported outcomes, pain, and quality of life. So the median age of patients on the adult cohort was 22 years of age, 67% were male. The target NF volume for this cohort was 557 milliliters for the median volume. And the location being in the trunk, the head and neck, and the trunk and extremity is the most common PN locations. Here we had a partial response rate of 42%, so 8 out of 19 evaluable patients. Again, 2 other patients came off. Initially, 21 were enrolled, but those exhibited partial response, and 58% had stable disease. We had 5 patients that completed all cycles of study, stoppage rule, discontinuation. There were 6 patients who had to come off at cycle 8. We had built in if you didn't have a 15% reduction by cycle 8, you needed to come off study. And then 2 patients came off for DLT, dose-limiting toxicity, and 6 patients also for low-grade adverse events. 7 patients required dose reductions, and then the most common AEs with cabozantinib, which I'll say is definitely different than MEK inhibitors, is diarrhea, nausea, hypothyroidism, which is often asymptomatic, but you'll see an elevation in thyroid stimulating hormone, fatigue, and then the palmoplantar erythrodysesthesia, which is a common skin finding that you can see with cabozantinib. All right, switching gears back to the last MEK inhibitor here, which is trametinib, MEK1, MEK2. FDA-approved indications for other histologies for sure, melanoma, advanced non-cell lung cancer, subsets of thyroid cancer, just doesn't have the FDA approval yet for NF1-related PNs, but has been reported in some smaller trials and case series as well. So in a phase 1/2a dose escalation trial, they escalated the trametinib from 0.0025 to 0.4 milligrams per kilo per day. It's for pediatric patients, 1 month to less than 18 years of age. The median age on this study was 6. Medically significant unresectable NF1 associated PN was the eligibility criteria. In an interim analysis, they had 46% or 12 of 26 who had a partial response over a median duration of exposure of 408 days. And then the most common tier treatment-related adverse events were paronychia and rash. All right, I know that was a big whirlwind here, but what I can tell you is that we have a variety of MEK inhibitors on market. 2 carry FDA approval. Others are definitely active within this this sphere of treatment. And then cabozantinib is another multi-tyrosine kinase inhibitor that has shown some activity for NF1 related PNs. So the big question is, how do we get to these patients who need help? How can we recognize an NF1 patient? How can we also recognize a plexiform neurofibroma in an NF1 patient? And that's really what the rest of this talk is going to be about before we hit some case examples. So initial screening evaluations for a patient who we think has NF1 really involves a lot of different people. So here at a pediatric center, we have a dedicated NF center, which will kind of go head to toe through all the things that can evolve or develop in a patient who has NF1. But I think the biggest thing is having a multidisciplinary team intact for kids and then even adults who have NF1 or if you're suspicious for it. So being able to examine for diagnostic criteria, which I'll show you on the next slide, review of developmental history and school progress, providing anticipatory guidance and referral to specialists as needed. And then really being able to confirm the diagnosis by identifying clinical features of NF1 with history, understanding with a PN what type of symptoms may be involved, pain, visual complaints, weakness, neurologic deficits, headaches, or seizures. That's also in the context of NF1 without a PN. Physical examination, focusing on the skin, bone, skeletal, neurologic systems, and then really making sure you have engaged eye doctors. So I can't perform a slit lamp exam in my clinic, but how do we identify these leash nodules or choroidal abnormalities are often very common in a patient who has NF1, as well as evaluating just from an exam for optic pathway glioma concerns. So that leads me to the diagnostic criteria for NF1, which was revised in 2021. And essentially, if you have a first-degree relative who has neurofibromatosis type 1, either through the clinical diagnosis or genetic diagnosis, then the offspring only needs, or the sibling only needs one additional finding to also be deemed to have neurofibromatosis type 1. So you need at least 2. The most common one that we will see is the cafe-au-lait macules, and it's not just one, it's 6 or more. The size does matter too. In prepubertal children, it's just 5 millimeters in size, and post-pubertal, you're looking for macules that are a bit larger at 1.5 centimeters in size. Again, the skin fold freckling, so axillary in the armpit and also in the underwear line in the inguinal region can be seen. The eye abnormalities being the leash or choroidal abnormalities, having distinctive osseous lesions, so sphenoidal or long bone hits one of the diagnostic criteria. And then moving over with the optic pathway glioma, which I'll show you a picture of soon, and then neurofibroma. So if you have one plexiform neurofibroma and 6 cafe-au-lait macules, you by definition have neurofibromatosis type 1. If you have 2 neurofibromas, maybe smaller skin ones, in addition to skin findings or first-degree relative, again, diagnosis of NF1. Additionally, if you have a genetic aberration with one of these clinical findings, you would also meet criteria for NF1. Moving over to what some of these clinical criteria actually look like. So the cafe-au-lait macules, often the first sign that we'll see, the most common one, present in over 90% of patients who have NF1. Not a marker of severity at all, but obviously you can see on this back that they're pretty distinct lesions. Just areas of hyperpigmentation. I would say people can have hyperpigmentation without having NF1, and hyperpigmentation sometimes is more common in darker skins. But if somebody's coming in the clinic and they have at least 6 or more, I mean, your radar definitely has to go up. The skin fold freckling here in the armpit region, you can kind of see what that looks like for the axillary freckling. This is usually detected by the age of 5 to 8 years. For the eye exam findings, you have the leash nodules, at least on the left side of my screen, nearly present in all NF patients as well. It does not impact vision, but it does require slit lamp examination to detect. And then the choroidal abnormalities in over 64% of patients. That requires a special type of ophthalmology equipment in order to detect as well. So again, making sure we have comprehensive evaluations for patients who are coming through. Here we have examples of what some of the neurofibromas look like. So the dermal neurofibromas are up top. Just kind of, they look like a little bit of skin outpouchings. I would say my younger patients, I don't often see these as much, but some of the older patients and definitely adults will have a lot of these, sometimes hundreds of dermal neurofibromas or cutaneous neurofibromas. And then below is an example on MRI of what a plexiform neurofibroma can look like. So you can see here on the brachial plexus, also involving the cervical region here, of this nodular kind of bag of worm-like enhancement, that white enhancement there. And that's what a plexiform neurofibroma would look like on MRI. In the middle, you can see some of the bony abnormalities of the tibial and orbital wing dysplasia, and then the optic pathway glioma. Very important thing to evaluate for. Usually can just be done by vision exams from an optometrist or an ophthalmologist. If you have new vision concerns in a patient who has NF1, definitely needs to be screened for. Not all centers necessarily do routine MRIs for the younger patients, but really rely on that vision exam. Then other manifestations and tumors associated with NF1. So just to think about from a tumor standpoint, we've got the neurofibromas, which we mentioned, our optic pathway gliomas, other low-grade gliomas within the brain, and then high-grade gliomas that can evolve throughout life and more commonly in the adult range. Malignant peripheral nerve sheath tumors, breast cancer, colorectal cancer, pheochromocytomas and paragangliomas, and even the rhabdomyosarcomas. And then from kind of just a systematic and just system-based standpoint, you have metabolic-related symptoms, so skeletal issues, endocrine issues, reduced muscle function, neurocog and behavioral, which we've talked about a little bit, but kind of the moya, I think also needs to be highlighted. That can commonly be seen in NF1, mood disorders, headaches and seizures, hearing impairments, and then cardiovascular and renal abnormalities as well. All right, now moving over to the clinical manifestations of NF1-PN. I think, again, it's important to understand that PNs can arise anywhere throughout the body, anywhere where a peripheral nerve may be located, maybe more commonly in the craniofacial area, the neck, pelvis, and lower extremities. Kids and adults, as far as what's going to be symptomatic, may be a little bit different for location, but that these tumors can also be asymptomatic. So again, just to highlight that not every tumor that's identified would need treatment. For the range of symptoms, we can see pain, swelling, or soft lumps on the body, numbness, disfigurement, visual or hearing impairments, airway obstruction, speech and swallowing difficulties, and then motor dysfunction and bowel or bladder dysfunction. So depends where that tumor is located, depends what it's getting in the way of, and then depends what other symptoms it could be causing. And then just another highlight here that there is a risk of a plexiform neurofibroma evolving into a more aggressive malignancy, which on the complete other end is a malignant peripheral nerve sheath tumor. So really acquiring additional genetic mutations that would allow for that transformation or evolution to occur. We believe that there's a middle ground of this transformation, so something called an ANOOP, an atypical neurofibromatous neoplasm of uncertain biological potential. Used to be an atypical neurofibroma, but often I'll have patients where we have a plexiform starting to look a little bit different. Maybe it's a little hot on PET, maybe it's causing some pain. Definitely do a biopsy. If I have concern, I just take it out. So we know that treatment for an ANOOP will prevent continued transformation into a malignant peripheral nerve sheath tumor. And then having that really high index of suspicion for an MPNST, because if localized, those patients can be cured. Once metastatic, it's a very hard journey for a patient with an NF1 metastatic MPNST. The diagnostic considerations in NF1-PNs, there's no agreed upon definition. I'd say surprise, but I'd say we've actually gotten to some agreed upon definitions to date. But as far as radiologically, they just look like PNs on MRI. So often if you have a patient coming in where you see something on your clinical exam, you get the MRI, that's enough to say, hey, this is a plexiform neurofibroma in my patient who has NF1. You don't need to get a biopsy. We don't need to have pathology analysis to dictate this is a plexiform neurofibroma. And then I alluded to it on the last slide, but sometimes if you're a little bit worried about malignant transformation or part of that tumor changing, sometimes getting a PET scan may help. We look at the overall FDG avidity or SUV uptake. And so areas that are a little bit hotter in the tumor should definitely be concerning, requires biopsy or even removal for the best evaluation of pathology there. The workup and screening considerations for NF1 plexiform neurofibromas. All individuals with NF1 should be assessed for the presence of a PN. So that should be part of their comprehensive NF1 evaluation, head-to-toe clinical exam. We haven't moved to the advent, at least in pediatrics, where everyone's getting a whole body MRI, but I would say that my adult colleague will often, if we haven't diagnosed a PN, sometimes start with a whole body MRI just to see what the tumor burden could be and what requires follow-up as the patient continues to age. And then standard evaluations, typically things you would do in clinic, H&Ps, MRIs are imaging modality of choice if there's a symptom or if we see something on exam. And then often just routine surveillance of these tumors. So even if they're asymptomatic, we do require keeping an eye on them due to that risk of change kind of throughout the lifetime. And then imaging for an NF1-PN, basically MRIs are the imaging that we do. The baseline whole body can be done in adult patients. We're about to launch a study seeing about the utility in pediatric patients. Obviously different when you need sedation versus not and things like that. But the whole body MRIs are not with contrast and they're a little bit cruder. So if you have a specific area of concern, making sure that you're getting a very dedicated MRI for that area to really evaluate the extent and burden of a PN. Surveillance MRIs, and then treatment response as well. So I'd say, these are slow growing tumors. We don't expect response to happen overnight, right? On a lot of those trials, we're saying at least 8 cycles before you get an initial response, major response like a year and a half in. So I'll usually image about 6 months into treatment, maybe sooner if I'm worried about a certain location. But giving the tumors time to evolve makes a lot of sense. And then lastly, we'll be able to end up with some clinical case scenarios here to hopefully guide the diagnosis and workup and put some of our words into action. So we're going to start here with an 8-year-old female. So patient dashboard, she was diagnosed based on family history. So her mom had neurofibromatosis type 1, and then she had cafe au lait maculas as well. So 2 diagnostic criteria made the diagnosis. As she aged, she noted to have a symptomatic plexiform neurofibromas, and you could see these externally. So you could see kind of bogginess to the skin on examination behind her ear, kind of on the right flank, left pelvis, buttocks, and thigh region. And by the age of 8, she was starting to have pain with sitting. She required a protective positioning or a donut, so one of those kind of cushion donuts when she was sitting on her desk chair. Mom was also describing a slightly altered gait when she was moving. She had had no prior medical or surgical intervention, and then repeat imaging at that point, being an MRI, was ordered by the NF1 clinic. So I'll say as an oncologist, I usually have patients referred to me. I'm not always doing that first screening evaluation, but for this patient, met the NF1 diagnostic criteria, has external exam findings, has symptoms, definitely warrants further imaging evaluation to see what's going on. And so here's just a screenshot example of part of her plexiform neurofibroma burden. I'm not sure if you can see my arrow, but in her buttocks region, going down her leg and then down her leg as well to where that tumor burden is. I didn't show other screenshots, but you could definitely see other components behind her ear, also kind of in the flank and retroperitoneal region too. So at that point, she was referred to oncology for discussion of treatment options. And here the indication for treatment was pain. So I don't have evidence to say that these were aggressively progressive per se, but they're definitely impacting her day-to-day activities and quality of life. So baseline imaging, and then she was ultimately started on a MEK inhibitor. So we knew that we had FDA approval for a MEK inhibitor. She started treatment a couple of years ago. So at that point, we only had one FDA-approved MEK inhibitor, and that's what she went on. And I would say in 3 months into treatment, she was already feeling that her pain was largely reduced. And for her, they were actually seeing a decrease in size and her tumor burden, which is pretty cool. So we can claim that we've had symptomatic and radiographic response to treatment when we start to look at the MRIs throughout. And then this version of an MRI is showing you what treatment has looked like 2.5 years later. So the arrows are pointing where the tumor burden initially was, kind of snaking down that nerve region. And then 2.5 years onto treatment, you're going to have to trust me, but the arrow is trying to point out some of the residual neurofibroma burden that remains, but you can see as a markedly different and drastic reduction from where she was starting. Side effect profile to medication, extremely important, right? So I'm glad she's getting a response, but is she tolerating the med? For her, luckily, she had grade 1 acneiform rash and some hair lightening, which you can definitely see on these MEK inhibitors, even some hair thinning as well. And at this juncture, the plan is to continue treatment indefinitely with obviously regular toxicity monitoring and make sure that we're not missing anything else. I would add that if we were ever to consider stopping treatment for whatever reason, that at this point, a lot of us will wean off of medication and not stop medication cold turkey. So we don't want to see a rebound growth effect and obviously a rebound symptomatic effect. But a good example of identification of a plexiform and initial response to treatment on an FDA-approved MEK inhibitor. All right, moving over to another case. This here is a 12-year-old male. So looking at his initial patient dashboard, he was diagnosed with NF1, a lot of things. So family history is positive, cafe-au-lait macules, and here you can assume 6 or more, axillary and inguinal freckling, cutaneous neurofibromas, and leash nodules. So really hitting off a lot of that diagnostic criteria. He also had Fragile X syndrome, which definitely led to his kind of developmental abilities and comprehension in conjunction with the NF1. He had a known right neck plexiform neurofibroma that was palpable, and it would fluctuate in size. So at times it would appear bigger when he was having an emotional outburst or with exertion. Then it came about that at school, it was noted that he was having trouble drinking milk or swallowing milk. And so he was referred for a local evaluation, which at that point, local ER noted a 90% oxygen saturation, thought, hey, maybe it's just some pneumonia or sinusitis, and provided Augmentin. So I would say kind of local areas or even, whether it's emergency rooms or primary care providers, really having an understanding that this is a patient who has NF1. Clinically, we think we've got a plexiform. Now, if we're having any concerns with, swallowing or saturation, maybe we should do a further workup versus just providing an antibiotic. Luckily, the school again had some concern about swallowing, and I say luckily because at that point it prompted further evaluation and then a hospital admission. At that point, an admission to a hospital that had an understanding of NF1 and potential complications. And so he underwent a swallow study, which was luckily normal, and then had an MRI and an MRA obtained, which at that point showed interval increase in the size of the right plexiform neurofibroma, which caused an increase in the airway compression. And so the arrow here is pointing to kind of the external point of the plexiform, but all of this kind of white nodular tissue, that's all the plexiform neurofibroma. And it's pushing up against his airway at a young age. So this is a concern of a plexiform located next to a really vital organ structure, where if it's going to continue to grow or progress, could be extremely problematic for that patient. So here, after a multidisciplinary team discussion, he was started on medical therapy. They did not feel that acute surgical intervention was warranted. So not acute airway compromise, but at risk for airway compromise. Indication for treatment, preventing airway compromise, given the high-risk location and recent interval growth. We'll say that he was started on a MEK inhibitor, which provided stability over time. And then as the patient aged, we know that his risk of growth of tumor decreased, right? So we start at the very beginning of the talk that the highest rate of growth is in the youngest of children. And as we hit adolescence and young adulthood, we really don't expect these tumors to grow all that rapidly. And so at that point, decided to observe the patient off of therapy. So he was having a variety of side effects as well. So looking at the pros and cons for why we're treating and symptomatically what he was experiencing. He had most notable side effects of paronychia and required some nail bed removal a couple of times. He, off therapy, was noted to have an MRI with a slightly progressive, but maybe potentially rebound growth of the tumor. And then also decided at that age, however, to get a PET scan. So anytime we're seeing growth at an older age or new symptom at an older age, just getting that reassurance of what a PET may look like, I think can be really helpful. So you can see here on the PET that there is a focal area that's ever so slightly brighter than the rest of the plexiform. And so with that, we did decide to biopsy it. Luckily, the biopsy just showed regular neurofibroma, and so he was continued to be observed. The tumor itself kind of really stopped growing, remained stagnant, and he's doing really well off therapy at this time. He's now 20 years of age, and so requires continued close clinical monitoring for both the risk of malignant transformation in the future. But at this point, his indication for treatment has kind of gone away. I would also add that we know that medications like a MEK inhibitor wouldn't prevent malignant transformation. We also know it doesn't cause malignant transformation. So just the MEK inhibitors or the medications we have to date are strictly for treatment of the plexiform neurofibroma. Then we'll hit our last case, which is a 14-year-old male diagnosed with family history, Capsular macules, axillary gonal freckling, cutaneous neurofibromas, and leash nodules. He additionally had autism, ADHD, and anxiety. So I said the first two can commonly be seen with NF1. And at the age of 3, though, he was actually diagnosed with a left lumbar plexiform neurofibroma. So family and his physical therapist noted issues with some of his lower extremity movements. And he was also complaining of some intermittent back pain, prompting his initial imaging. So the question is, we know a patient has NF1, but how do we get to that PN diagnosis? So for him, it was some abnormalities with therapy, with gait, and with potential pain. And then his PN was ultimately followed by the NF1 clinic over time. So they felt like the pain wasn't problematic enough to actually get in the way of his day-to-day activities, and just made sure that the PN wasn't causing him problems as he aged. Then he presents to the NF1 clinic, and at that point was noting worsening back pain, and that prompted an MRI, which is compared to an MRI 2 years prior. That MRI found a more focal, heterogeneously, and uniformly enhancing area within the plexiform neurofibroma, which always raises level of concern. And so then the PET scan was ordered. And this is a nice picture of what that PET scan looks like. So you can see the kidneys are flanking it. So the kidneys are obviously avid as the tracer goes through them. But then the tumor is in that left lumbar region. And then there's one region or nodular area within that plexiform that's extremely bright and well circumscribed. And so we were very worried about that. He underwent an IR-guided biopsy, and that showed an aNUP, or an atypical neurofibromatous neoplasm of uncertain biologic potential. And what I've told you is that we get rid of aNUPs to prevent transformation to a malignant peripheral nerve sheath tumor. So he ultimately had that resected. At that point, he was closely followed with imaging. 3.5 years later, he had another excisional biopsy of a nodular component of his PM in conjunction with a spinal fusion surgery. Pathology at this time was also concerning for an aNUP. So here's a kid where keeping a really close eye on things, going in from a surgical resection, not necessarily removal of his entire tumor, that's not possible, but resecting the areas of concern was found to be very helpful for him. Went back and forth with the mom. There was really no indication to start systemic treatment as far as what his symptoms were. And as I mentioned, no indication to start systemic treatment for further malignant transformation. And mom felt that it would just be easy to kind of see if his pain would worsen. But at this point, he was getting fine, sitting fine, kind of going through his day-to-day activities. So we had elected to observe. But just a good example when something doesn't look quite right, to definitely do further testing. And hopefully be able to work with your surgical colleagues from a multidisciplinary approach to resect that tumor. I always tell them it's a ticking time bomb. It needs to come out. We cannot play around with this. And that tends to push things forward to getting patients what they deserve. So in conclusion, plexiform neurofibromas develop in about 50% of patients with NF1 and are typically congenital or manifest in early childhood. A patient may have an asymptomatic and a symptomatic plexiform neurofibroma. The growth varies between tumors and between individuals. So you may have 2 tumors in the same patient, maybe one's progressing and one isn't. Then obviously across individuals, that growth rate may be different. Most patients will have greater than 1 or equal to 1 plexiform neurofibroma associated morbidity. These tend to worsen over time without treatment. And then they are benign tumors, but they may progress to an atypical neurofibroma and an aNUP, and then undergo transformation to MPNST. There's no agreed upon PN definition, but again, radiologically on an NF1 diagnosis, you should be able to render it. If you don't have an NF1 diagnosis, then often it's the pathology that will bring a patient into clinic to consider further treatment options. And then imaging plays a vital role in the recognition, diagnosis, and further treatment of patients with PN. Then we'll hit these just credit opportunities here. You can complete a brief post-test and evaluation form, and then we'll see about the accuracy of the post-test here. And please feel free to visit us at www.practicepointcme.com to review other archive presentations of interests. Then I'll leave you here with the QR code. But it was great to be able to speak with you all today. Thank you.